Anyway, I look forward to it. I think we're going to have fun.
Yeah. We'll enjoy together.
Yes, of course, yeah. So, we are starting?
Yeah,
No,
just
first
I
of all, he
will tell
will
you.
introduce.
Once I will give an introduction, small introduction, then we'll start, sir.
Okay. It's so good to have you as an expert, huh? Should I be?
Yes,
is
sir.
it necessary
Yes, sir.
Is it necessary for me to mute my microphone?
No,
to
you
stop
can,
sound?
you can, and now it is recorded. All getting recorded. Whatever you are talking is getting recorded.
But to mute, I mean to stop the echo. Let me know if I need to.
No, there is no echo.
There is no echo.
You can mute yourself. That's all.
Okay.
I will take 1 or 2 minutes. That's all.
I don't hear anything.
Just now it stopped everything. Just a minute.
નવીનભાઈ તમે તો ત્રણ જગ્યા બે જગ્યાએથી દેખાવ છો.
Yes, 3 times. then I can manage, yeah.
ના તમે ઓલું મોકલ્યું તો મારામાં તો ઊંધું થઈ જાય છે.
You just have to mirror it. There is a setting, you can mirror it.
Yeah, you can mirror
Go
it.
to the virtual setting and you can mirror it.
Yes, perfectly right. So
We have two computers.
I'm just starting, sir. I'm just starting, sir. Okay, is it okay, sir? Yeah. Now we are very much thankful to all faculty for accepting the invitation of Gujarat Orthopedic Association for sharing, contributing, and learning together. And we are really thankful to Dr. Safiq Pirani sir for accepting our invitation and sharing the master information about CTV. And same way, Dr. Matthew Varghese. So let me tell you that this is the 58th Golden Jubilee webinar of Gujarat Orthopedic Association. So we all welcome you, all the viewers, we are welcoming you. And as you see on the screen, it's not sharing, you are not seeing sharing?
It's not sharing.
It's not sharing, okay. So that means there is an issue. Okay.
Yeah, now it's sharing.
Now it's sharing, yeah. I forgot to write. So we all we welcome to all the viewers, and for the viewers, just click here the recordings and you will get all the recordings of the previous webinar. And as you go down here, there is a present webinar. Just now we have removed the previous streaming of welcoming, and now you are getting this new video. Just click this red arrow and you will be there in the webinar. Just below that webinar, you have a one window for asking the question. This is a Slido window. Just type your question. I have limited 160 characters to have a crisp questions, right questions, and just click the send button. It will come to me and I will pass on to moderator, Dr. Kamlesh Bhai and Dr. Dhiren Bhai, and to the faculty. Some of the devices are having the ask button. Just click here the ask and you will open up the question window, then type the question. Some of the devices are very small and they are seeing from the mobile devices. They can just record the audio or video in their WhatsApp itself, and just click WhatsApp Dr. Navin. It will come to me and I will ask the question to the moderator and the faculty. Let me introduce shortly our today's guest faculty, Dr. Safik Pirani. You everybody know him about CTV. He has done a great work on CTV, and we all know our own national faculty, Dr. Matthew Varghese from the Delhi St. Stephen Hospital. Today, our webinar will be moderated by our own Honorary Secretary of Gujarat Orthopedic Association and Pediatric Orthopedic Surgeon, Dr. Kamlesh Dev Murari, and Dr. Dhiren Ganjwala is the President of Pediatric Orthopedic Society of India. I will be just coordinating between you and I will be asking the questions. So, Dr. Pirani, now you can take over the screen. Just share the screen. Automatically, my screen will go, sir.
Kamlesh.
Yeah.
Yeah.
So, hello everyone, and welcome to today's webinar or clubfoot. And clubfoot, it's very common deformity, and I think all general orthopedic surgeons are treating them. So that is the main reason we have planned this webinar. So I would like to introduce today's faculty of webinar, Dr. Safik Pirani. So he's a professor at Department of Orthopedic Surgery at University of British Columbia Medical School, Canada. And he's widely known for his clubfoot assessment tool like Pirani Clubfoot Severity Score. And Dr. Pirani has been widely recognized for his clubfoot work in all over the world. And in a lighter mode, I will. He has a root from Gujarat. When I met in Nagpur, we speak a lot of in Gujarati language. So very warm welcome to Dr. Safik Pirani on this platform, and another our faculty, Dr. Matthew Varghese, and he is head of department of St. Stephen Hospital, New Delhi, and he's a known, very known for his charity work, and I think so many time in India he's appreciated lot of work for a charity. I think Bill Gates also appreciated his charity work. So welcome, Dr. Matthew Varghese, and I thank Dr. Dhiren Ganjwala for planning this webinar. There are no words about it, and thank you, Navin Bhai, for you are backbone of our Geo webinar series. So let's hear from our faculty. Yes, Dr. Safik Pirani. Thank you very much. Yeah.
Thank you very much to the organizers and the hosts. Can you hear me okay? Can you
Yes,
see my
very well,
screen?
sir.
Yeah?
Very well, sir.
Yeah.
Very well, sir.
Thank you. Well, everybody, welcome. This is an unusual time of COVID, where we're all separated, and yet you can see. So this is a way of everybody getting together and learning from each other despite COVID. Anyway, this is a talk about the Ponseti method, and you can see a picture of Dr. Ponseti and his book, and a picture of my university. So I'll get right into it. I think the most important thing to understand is part of the pathology. And really, if I can bring it down to one point, pathology, it starts out with postural medial retracting fibrosis, as Dr. Ponseti has elegantly shown in his dissections. And once you get that postural medial retracting fibrosis, of course, the reason for it is many, but this is the primary, this is the pathway, what you call the path of least resistance, or the final common pathway of all those factors, which comprises really an abnormal thickening and shortening of the capsular ligaments and tendon sheaths, and everything posterior and medial to the ankle joints. That gives you like a spot weld on the posterior medial part of the foot, and it collapses. It brings all the tarsal bones, it deforms them, and it causes all kinds of tarsal malalignments and tarsal malformations. As you can see, again, this is Dr. Ponseti's dissection. So if we understand the pathology, then this is my contribution regarding India. That you see, this is a picture of Gantia, right, on the right-hand side. Okay, so you can see the Gantia is twisted like like a clubfoot. If I was to say to you, how do you make that Gantia straight? It would be impossible. You break it, right? But Dr. Ponseti, he worked out how you can take this Gantia of a foot and make it straight. And it's incredible. It's really amazing. And what Dr. Ponseti said, the most important thing to do is to understand this sentence, which is from his book, A Well-Conducted Orthopedic Treatment Based on a Sound Understanding of the Functional Anatomy of the Foot and connective tissues and bones to changes in direction of mechanical stimuli. So 2 words, functional anatomy and biological response. And the functional anatomy, and you'll see this, I think, over and over again, is to understand how the subtalar joint works. Let's see if I can make this work properly. The subtalar joint is a very funny joint, but it only moves in one of 2 ways. It goes inverts and everts like this, but when you evert, you abduct and extend, and when you invert, you adduct and flex. So this is showing it from the back, and then this is showing it from the side, that when you abduct, it extends and everts. When you adduct, it flexes and inverts. So that's a subtalar joint. It only moves one, but it's a complex motion. So if we understand that, then we can picture, again, I repeat, in the neutral position, the calcaneus is completely under the talus. But when you supinate, the calcaneus adducts, inverts, and flexes. And when you evert, it abducts and extends. So the reason why I make that is because this is the importance of functional anatomy. As you go from the deformed foot to the corrected foot, the calcaneus has to evert, extend, and abduct. That's functional anatomy. That's what Dr. Ponseti understood, and what we have to do when we treat the club foot. Always straighten the gantlia. But what about this biological response? This biological response here is a schematic of the talus, which is deformed, the navicular, which is deformed, the posterior medial retracting fibrosis, and the posterior, the tibialis posterior tendon pulling the navicular medially. So when you manipulate, okay, what you have to do is you have to stretch that spring and then bring the navicular down over the head of the talus, and with your thumb as the fulcrum. And you see now the dotted line, you can see there's been some change in the shape of the talar head and the navicular. And we've shown this on our MRI studies, that immediately that happens. And then what we need to do, we need to then put a cast on, right? And the cast must be snug enough to hold that. If it's not snug enough to hold that, or tight enough to hold that, it's going to relax and everything is going to slip back. And that's the concept of an effective cast, that you must put on the cast in a position that's not too tight, not too loose, but just perfect. And if you do that, then when you take the first cast off, now you can see the red has turned into orange, the string is stretched, and the shape is improved, the position is improved. And then you now you do the further manipulation and casting, and you can see exactly the same thing happening again. This is the biological response that Dr. Ponseti was talking about. You put another snug cast on, and then what you end up, when you take the last cast off, is the talar navicular joint is corrected. So in short, colleagues, functional anatomy and biological response. So, and you can see here our MRI studies. This is published a long time ago. You can see the correction of the talar navicular joint over the casts, over the weeks as the foot corrects. So how do you do it? Well, I want to emphasize a concept of effective manipulation and casting versus ineffective manipulation and casting. So here you see a baby who's feeding, breastfeeding in this case, completely relaxed. If the baby is relaxed, you can do this maneuver quite easily. And so you get an effective cast. Not only because if you don't have the baby relaxed, then the posterior, and the baby is moving, then the tibialis posterior tendon, the muscle tendon unit will contract, and it'll stop you from pulling the bone over. That's what happens here. If you have a baby that's crying, what I do is I walk away if I can, if I can make it fit my situation. Because if I try and manipulate, I'll be fighting against the baby. The cast will go on fighting against the baby. And when the cast is removed, I've not made any difference. So this is the equivalent to this would be failing to reduce the distal radial fracture during your reduction maneuver and then putting a cast on and walking away. We don't have an x-ray we can take of this. If we had MRIs that were readily available, you could check this like a broken wrist. But this is the concept. So if those two things are understood, those three things are understood, now we talk about the sequence of correction, how to straighten the ganthias. Well, first you have to correct the cavus. All right, so that's actually supinating the forefoot. And we'll hear about this more with Dr. Varghese, I'm sure. Then you have to abduct the foot under the talus. That would start moving that subtalar joint and like that. So that when you abduct the foot, the subtalar joint pronates and corrects the varus and some equinus simultaneously. So in my hands, for effective, and this is how I do it, I have everybody sitting on a chair. I have the mother breastfeeding, and I have an assistant, and I have myself doing the casting, doing the manipulation. The assistant can do the casting, or I do the casting, depending on whether my assistant has this necessary skill. So when everybody is sitting, that works. If I'm only by myself, one person, and the baby is crying, we can't do it. It's impossible. It's actually almost dangerous. So when we have in my situation, I have an assistant who has plastering skills. They sit at the end of the feet of the baby, distal to the baby, whereas I sit to one side, because in that situation, my hand positions are much better. I'm able to get my hands in where I want to do so. So here, how do we find the head of the talus? You find the tip of the fibula first with your thumb, always easy to feel. And then in the newborn, the head of the talus is about 1.5 centimeters in front of the tip of the fibula. And you can just directly anterior. If you go inferior and anterior, you'll find the anterior process of the calcaneus. So that's how you find the head of the talus. And you can see how I bring my index finger and middle finger on the inside over the medial malleolus of the hand of this is a baby's right foot. I'm holding with my left hand, thumb over the head of the talus, index finger, middle finger over the medial malleolus area, not touching the heel. And then my right hand, long finger goes underneath the long axis, underneath the plantar aspect of the first metatarsal. My index finger goes on the medial side, and my thumb goes on the top. That's how I hold the foot. Okay. Then the baby is relaxed, and then we do our manipulative maneuver, and that's it. You supinate let me go back. The long finger, this finger, supinates the foot, and the index finger abducts the foot. Remember that. This stabilizes, this supinates, this abducts. So here you see the long finger has supinated the foot, the index finger is abducting the foot, the thumb is stabilizing, and this thumb is on the head of the talus as a fulcrum. There. Then we have to move our hands out of the way so that the plaster technician can put the cast on. How do you do that? In my hands, once I've got the foot stabilized, I take my hand, this hand, and I move my thumb from A to B, B being the lateral side of the knee. And let me say that to go from here to here, I take first my thumb from the head of the big toe here, and I put it on the head of the talus. So I maintain my fulcrum. And then I move my right hand thumb from the head of the talus to the lateral side of the knee. And then I once I've stabilized this, the fulcrum really becomes here. It's a second class fulcrum, but it becomes there. Then I take my thumb and I move it back over here. Now I've exposed all of this for the person to put the cast on. So the putting on of the cast is done by the assistant whilst one person is holding. You'll see there are two very tight wraps of Sofro over the thumbs. and the fingers. And then that is 50% overlap until you get to the heel. And then there are three wraps all the way up to the leg. And personally, I only put on below knee cast first and then above knee. And then when the plaster goes on, there's 4 very tight wraps of 2-inch here. And then up to here, there's a 3/4 overlap. And then here, there's three wraps up to here. And then you mold the cast into the position. Once the way to mold the cast is you have to be aware of spaces. Okay? There's a space underneath the arch, there's a space in front of the ankle, and there's a space behind the ankle. And these spaces have to be eliminated by molding. Your thumb sits on the plantar aspect and makes it a dent here. The index finger is over the anterior part of the ankle, but you notice these arrows. You must move your finger up and down so that it doesn't dent. And then the other finger of the other hand comes here and it moves backwards and forwards and eliminates that space back here, and also molds around the medial malleolus if you can manage it. Then we put the above knee cast on and we trim the cast. And this is the first cast. And if we put it on correctly, we are maintaining the stretch, we're maintaining the shape and alignments, we've softened the fibrosis, and this eventually will permit further stretch so that you repeat the maneuver with the second manipulation. And it's exactly the same. Hold the thumb in the same way. You can see that in this picture, the index finger actually is behind the fibula. So that is another option rather than putting on the medial side of the ankle, whichever you feel more comfortable with. But in principle, it's the same thing. You thumb over the fulcrum, long finger supinates, index finger abducts. And the second cast, again, maintaining the stretch for an effective cast. And the third manipulation is exactly the same principle. So here's a movie of Dr. Ponseti. This is available off the internet. You can see, I just wanted to show you this real club foot. Okay.
Yeah, Dr. Shafiq, shall I ask one question?
Yes, of course.
Yeah, fine. So it is a fantastic thing. Now, sir, before we will go for a sequence of the treatment, like a cave. So
yes.
it is needed to assess the deformity. So how can we assess the deformity and why it is very important to quantitate the deformity?
Kamlesh, can you put your mic nearer your collar so that your voice is clear? Yeah.
Maybe I can just refer that question to another talk of mine where the pyramid score is.
Okay, sir.
Yeah, it's a very important question actually, because it correlates with the idea of an effective cast. How do you know your cast is effective? You know, how do you know if the money in your bank account is going down or going up unless you check the bank account? Right?
Yes.
So this is I want to show you. This is again Dr. Ponseti. Hopefully you can see this, but you can see he is holding the foot in the corrected position, and you see how the wrap is going on very tightly. Okay, and it's a dance of 4 hands. It's a dance of 4 hands and a foot. Right? It's complicated, but you can see here how the wrap has gone on, and Dr. Ponseti is, of course, he's a master, so he's put the wrap all the way up to the top, and now you can see the plaster going on. 1, 2 wraps, the fingers are inside. 3, 4, and only once the plaster's gone away does he move his fingers outside. And then you can see he's maintaining the stretch, and his fingers are moving gently around. The plaster technician knows exactly what they're doing. And there you go. That's the below knee part. And now you can see the foot is in the position it was when he was first starting to cast. It has not slipped. Now this is the second, the first cast has gone off. Now the second cast, he's doing exactly the same. You see he stretched the foot into the correct position, stretched that posterior medial retracting fibrosis. You can see how the soft roll is going on very tight on the foot. Don't be afraid, but not too much, only 2 layers, 50% overlap, 3/4 overlap once you get 2/3 or 3/4 overlap once you get above the ankle. And now you can see again, the plaster is going over the fingers, because he wants to keep hold of the foot. He doesn't want to let it go. You don't change the shape of the foot after the plaster has gone on. The plaster must be put on with the foot in the corrected shape. And you can see now his finger, his index finger, right hand, molding behind, molding above the calcaneus, and holding the foot in the corrected position. And there he's supinating and abducting. And there is the cast that is put on, extended. He's got it extended above the knee now. And then, of course, he has to trim the cast away so you can see the toes. So here's the sequence of correction again, which, and then once you've got the cavus, adductus, and varus, and half the equinus taken away, because as the subtalar joint abducts, you get some extension, then you have to perform the tenotomy to complete the correction and put the last cast on again in a position of correction. So here's the key anatomy. The Achilles tendon is here, tiger country is here. There's a bit of space, that's the posterior medial tendon, the nerves and the blood vessels and the tendons. There's some space here, a little soft space here, which is safe. This is not safe. And of course, beware of the sural vein and nerve if you go too deep. The way I like to position myself is the baby is here, the assistant is holding the knee extended and the foot dorsiflexed. In my position, lots of people do it different ways, but if the assistant is holding the knee extended and the foot dorsiflexed and the baby is turned a little bit this way, then that exposes the tendon and brings it available to me. If necessary, the parent can be here if they want to, at least in my clinic, and this is all done under local anesthetic. So once the assistant is holding the foot in this position, I take my finger and I palpate the tendon. And it's a bit like palpating the extensor pollicis longus tendon over here. If you put it on stretch, it's very easy to feel. So I am not guessing where the tendon is. I am finding out where the tendon is, where the tip of the calcaneus is, the posterior aspect, and going about 1.5 centimeters above it, because you don't want to damage the calcaneus. And the tendon is actually thinner here than it's over here. And once I know where the tendon is with my finger, then just medial to it, I put in maybe 1/4 cc of any kind of freezing solution that you want. You don't want to put in too much because then you lose the anatomy, you can't feel it. Now you know where the tendon is. You felt you put a bit of local in. Now you put in your blade. I like to use the beaver blade, but failing that, any kind of small blade, 15 blade would be okay. It's put in with the blade parallel to the tendon. Okay, it's not put in any other way. You must never make the sharp side go towards the neurovascular bundle. And then you rotate the tendon so the sharp side now becomes next to the tendon. And then you move the blade towards the tendon, and because it's on tension, the tendon snaps. Now, if it doesn't snap, you haven't done it. You must have a snap, and you must have sudden ankle extension. If you don't have those two things, you have an error. You have made an error. And then here you can see pictures of the same thing. The knee extended, the foot dorsiflexed. I put some freezing solution in. I put my blade in. I rotate it and snap. And the blade is only in for 3 or 4 seconds. If you know where you're going, it's like a cruise missile. You must make that blade like a cruise missile. It goes right to the spot. Then we have to have bracing. And the bracing is nighttime for 2 months, sleeping a day and night, 23 hours a day for 2 months, and nighttime only till age 4. And this is a child, Dr. Ponsetti's video of a child walking, now walking. Amazing. You see that the tendon is healed in the lengthened position. There's no compromise in toe walking. And then this is also a patient of Dr. Ponsetti's. I think this is his first patient or second patient from the 1960s or maybe later. But he is a pharmacist in Iowa, and his gait is fantastic. And look at him. He's hopping at his age. And he also runs marathons. So that's a very brief overview of the Ponsetti method. Sorry, it's a lot of slides in a short period of time, but given you enough of an overview as to what it's all about.
Yes, sir.
Yes, sir. So now I would like to ask Dr. Matthew Varghese. So there are various description of pathoanatomy. All clubfoot like Scarpa has mentioned and Ponseti in 1996 like fundamentals of treatment. So I would like now we have a more sophisticated method of imaging to quantitate the deformity. So give the current concept of all terminology like subtalar motions and how it everts. Already Dr. Safik has already mentioned, but we want more brief about the subtalar motions and all terminology.
Meanwhile, he's sharing, there is one question. Probably it is answered already, but Dr. Chandli is asking to Dr. Safik, Ponseti cast, should we try to correct equinus or it is absolutely necessary to do tenotomy? Textbook varies and please mention Ponseti initial teaching.
So this was a question I asked Dr. Ponseti in the year 2000. And Dr. Ponseti told me the answer. And it was very clear. He said that the collagen, medial and posteromedial, the capsular ligament collagen is stretchy like a spring. The collagen fibers are not like this, they're kind of like this. So they can be stretched. And that's why stretching works. The Achilles tendon, however, the collagen fibers are all lined up like this. They're very difficult to stretch. You can stretch them, but it takes 3 or 4 casts. Okay. So what you're doing is you're facilitating a quicker correction of equinus by doing the Achilles tenotomy. Not only that, but you're protecting the head of the dome of the talus. Because if you stretch, if you dorsiflex against the tendon, then necessarily you're going to change the shape of the dome of the talus. Its cartilage is bendy like my nose. And you will end up with a flattening of the dome of the talus, which sometimes you see on x-rays. If you take x-rays of children who've been treated with Ponseti method, you say, well, how come this dome of the talus is flattened?
Okay, Dhiren wants to say something. If you have any issue with the sharing, Dr. Matthew?
No, should I start off?
Yeah, you start off. The discussion will go on. Meanwhile, we'll utilize this time for that.
Okay.
Your slide will be on.
Is the slide on now? No.
Yeah, slide is on now. Make it full screen. Make it full screen, please, sir. Yeah, just click that. Yeah. Dhiren, what do you want to say?
Yeah, so like coming to that question about tenotomy, what Safik said is absolutely right. I would just like to share one of my early practice case. At that time, one of the parents, they were not willing for tenotomy. And I was also not very sure whether like we need tenotomy in every case or not. So I said that, yes, let's go for 2 or 3 plaster. So once like we carried out with plaster correction for equinus, after a few plasters, I realized that the correction is taking place at talonavicular joint, and it resulted into a iatrogenic midfoot break. So what I feel is like if we don't correct or take out the constraint which is there on the posterior side, there will be a false correction, not at the ankle, but the false correction at the talonavicular joint or at the midfoot level. That is one possibility. So if you are not going for tenotomy, make sure that actually the foot is getting dorsiflex at ankle and not at other area.
Okay.
Yes, Matthew, now you can start.
Yeah. Thank you, Dr. Shafiq, for taking us through the
again. Okay, go ahead, sir. Then we'll ask the questions. Okay.
Giving us the basics and giving us the overview. So you would notice there is a lot of repetition in what we are seeing and an overlap. And many of the slides have come from Dr. Shafiq Purani and Orgro Penny. And I must acknowledge that many of the slides that I'm using belong to them. I think it is important. The genius of Ponseti lies in his understanding of pathoanatomy of club. And the pathoanatomy, more important, you already heard about the retractile fibrosis and the biology of stretching that he's talked about. But what is more important is to understand how the subtalar joint moves. And for that, you need to understand the kinematics of the subtalar joint. What you see on the screen is that an adult foot anatomy skeleton, adult foot. Why couldn't I get a child's foot skeleton? Because the child's foot is almost all cartilage, except for small blebs of bone, ossific nuclei, and the rest of the bone, rest of the foot is all cartilaginous. And you're remodeling when you manipulate that cartilage into correct position so that it grows to become normal bone. That's the key to it. But to understand, we use the adult skeleton of the foot. And another genius is this teaching model of the foot anatomy to describe what happens in a clubfoot manipulation. So I have two models here. One is a small one is a large one. And if you notice, the small one is also larger than the foot of a child. See that? It's
Yeah.
much larger. But this is for the sake of understanding and explaining to you. So if you heard what Dr. Pirani said, you have cavus, adductus, varus, and equinus. Four key components of the deformity that we need to address in a child who is to be manipulated for club. So when we are learning to manipulate, we need to understand what happens when we manipulate this foot to each of these components and where do we put our fingers when we do our manipulation. You've already seen this slide. For the sake of saving time, I will not discuss this. But important thing to remember is what you see here as a deformed wedge-shaped navicular, a severely displaced navicular, as a wedge-shaped head of talus, adducted invertus calcaneus, a wedge-shaped distal calcaneus, a medially displaced cuboid. All these components get corrected by your manipulation. And once the foot becomes straight, you know that the development of the bone, the cartilage that gets ossified, gets into a normal situation. So here is the deformity as seen in the original specimen of a stillborn baby that Dr. Ponseti dissected. And that's the model that has been created. It's very ingeniously created by John Mitchell, who was the orthotist of Dr. Ponseti. And you can see the typical, so this is the model where you can show the different components of the deformity. That's the dissected specimen, and that's the foot, which is showing all the components of the deformity. And you've already seen some of these slides showing the MR evaluation that Dr. Shafiq Rani showed, that you correct the components of the deformity by your manipulation technique. So this technique has therefore been validated by long-term results, by short-term results, by looking at it through imaging modalities to know that the foot gets corrected. So here is the navicular, which is the cuboid, which is oblique, the calcaneocuboid, which is obliquely placed. Here is the navicular, which is there, and which is come close to the medial malleolus. So the manipulation corrects the position in a particular way. And this is because of the biology of that particular retracting tissue. However, if you do not correct it in the right time, you have this problem where bones held in a deformed position develops into a structurally deformed bone. So the talus, the navicular, the cuboid, the calcaneum, the final development is deformed. So now if you try to do it in an adult structurally mature bone, you cannot correct it by just soft tissue procedure. So that is something that you need to understand. You need to correct the foot as early as possible. Now the key to understanding, and honestly I must admit, when I started doing Ponseti, I learned it by just reading the book. And I did not understand these kinematics. I just read how do you put your hands, where do you put your hands, and then manipulate. It's only much later especially when I got to look at these models, that I understood how the manipulation works. So let's look at these two pictures. This is a picture of the foot skeleton from the top. And from the top, you see this is the talus has been taken off, and you have the navicular, they have the anterior subtalar joint, and you have the plantar calcaneonavicular ligament, and you have a capsule there. You have the posterior talar joint, and you have the middle subtalar joint here. So here, the subtalar joint with the navicular, with the ligament complex becomes a cup. That's the cup. So that's the view: posterior subtalar, middle subtalar, that's the anterior subtalar, and the navicular that is there. And the capsule together and the ligament together forms a cup in the front, into which the head of the talus. Now, if you see here, that's the gray. I hope you can make out the gray structure here is the talus. So the navicular is displaced medially, and the head of the talus is now more prominent laterally. So when you correct the manipulation, this relationship becomes normal. So the head of the talus articulates in the cup beneath that talus, and that Ponseti described as the acetabulum pedis. Now again, if you see in the larger model that I have, so you should first learn how to hold this model. This is the model of a right foot. I hold it with my fingers on the top, there like that, on top of the leg like that. My fingers go like that. And as Dr. Pirani mentioned, you feel for the tip of the lateral malleolus and go in front. Now, this is a large foot model. If I were to do the same thing, now this is the left foot. So you hold it with the right hand, with the fingers going on top. And I have my thumb coming here at the tip of the lateral malleolus, and I move anteriorly. So in this smaller foot, I move very little. I'm bang on the head of the talus. In this larger model, I have to move much more to be on the head of the talus. So in a small child, I move just a centimeter in front, and I am at the head of the talus. So your reference point for identifying the head of the talus is the tip of your lateral malleolus.
Dr. Matthew,
Yeah.
I suggest that at last, when you are not sharing, we'll be able to do a full camera on you so that you can show the models very well. At
Okay.
last, again,
Okay.
you repeat again, because in a small camera, they are seeing the slide and your camera also, your hand, but they are not able to see exactly what the model is containing. Right?
Okay.
So at last, we'll do again this part of your
Okay.
understanding of that on the model
So,
itself.
so you have the acetabulum pedis here, and you have the head of the talus which moves, which is in that. Now, the difference between the acetabulum pedis and the acetabulum is of the normal hip joint. The acetabulum is fixed, and the ball of the head of the femur moves. Here it is the reverse. The acetabulum pedis moves around the ball of the head of the talus. So you have clear distinction between the two. But the analogy is brought forward to understand that this acetabulum pedis can be manipulated to get the foot into a normal looking and a normal anatomy foot. So that is the key to understand it. And this Dr. Ponseti learned from studies of literature. And one of the key things that he studied was the fact that when you have a foot that you're looking at, you have the ankle joint. The talus is fixed in the ankle mortise. The talus is fixed in the ankle mortise. You're not moving the talus. It is a calcaneum and the rest of the foot which moves beneath the talus. So your manipulation is of the foot, and the foot, which included the calcaneum and the rest of the foot, Dr. Ponseti liked to call it the calcaneopedis block. The calcaneopedis block. And this calcaneopedis block moved the beneath the talus. Now, how did he get this brilliant idea of the calcaneopedis block? He got this from the analogy that Feyerabend described of the subtalar joint motion being like that of a boat on the surface of water. Now, here again, I'll have to use a little model, and I'm sure this is visible. No, I don't know.
So it won't be
Yeah,
that
yeah.
much visible. Yeah,
Is this visible? That's
partly.
the
Yeah.
origami model of a foot that of a ship that I have created. Now, in this picture, there is this boat on the surface of water, and on the surface of water, the boat moves forward. But does it move forward straight like that still? No, it doesn't. As it is moving with the waves, it is going up and down, up and down. It is pitching forward and pitching up and down like that. The next move, is that the only movement that happens? No. As the boat is moving and the waves are striking it, it is rolling from side to side. So there is a rolling motion that you see here. There's a pitch movement front to back. Is that the only movement? No. As it is moving forward, it is also yawing from side to side. So there are three components of movement that you have described, as described by Feyerabend in 1872. Remember how far back? How many years back? It's more than a century years back. And you're looking at this, and Ponseti read this article, and okay, that is a eureka moment. When he understood this is how it works, I still did not understand. How does the roll, the yaw, and the pitch of this boat become analogous to what we do in manipulation? It's only when I got this model that I started understanding. So let's go back to the manipulation that we do. We call this movement that happens, the pitch doesn't happen alone, the roll doesn't happen alone, and the yaw doesn't happen alone. On the surface of the water, all these movements are happening simultaneously in a coupled manner. And Ponseti described this as kinematic coupling, as described in the original article by Feyerabend. So kinematic coupling is what you need to understand, which means all the components of clubfoot that we are doing except for equinus, we correcting it simultaneously because the foot, the calcaneopedis unit, which functions as one unit, is working as one unit, and the manipulation is happening simultaneously. So that's kinematic coupled movement. So let's look at the normal foot anatomy. When you look at the normal, I'll come back to this with the videos. When you look at the normal foot, as you have supination. In supination, the foot is adducted, the foot is inverted, and it is plantar flexed. Look at the hind foot. This is the normal foot. This is not a club foot. The normal foot of an 18-year-old girl. So you have foot is adducted, foot is inverted, foot is plantar flexed. But look at the heel. Heel is in varus. Same way. So when you do the movement in a normal foot, so that's normal kinetically coupled movement seen in a normal subtalar joint. Let's look at the reverse. When you abduct and dorsiflex and invert the foot, looks what's happening. The hind foot also moves, and the hind foot goes into valgus position. In a normal foot, the subtalar movement is kinematically coupled, that the foot on abduction, dorsiflexion, and eversion causes hind foot valgus position. So you have this concept clear in your mind, you know that it works well in manipulation. So when you adduct, the hind foot is in varus. When you abduct, the hind foot is in valgus. Okay. When you're standing quietly, the heel is valgus position. When you're standing on tiptoe, the heel is in varus position. This is normal kinematically coupled subtalar joint. That's the concept of this. So if you have this model and you hold the thumb and put it on the fulcrum, now the manipulation, what is the key to understanding? the talus is fixed in the ankle mortise. It's not the talus that is moving. So you have to prevent any manipulation from causing a movement of the ankle mortise, the talus in the ankle mortise. So that is what you're doing by keeping your thumb on the fulcrum there. So when you do that, there is the fixation talus in the ankle mortise that is happening. And when you manipulate that one by one, you correct the deformities from supination of the foot is the first manipulation that you do. I don't think my video is working, is it? I don't know.
Yes, yeah.
Is it working?
No, no, your video I have stopped because there was a bandwidth problem. So your voice was cutting. So temporarily you are not seen, but your voice and slides are seen, sir.
Okay, thank you, thank you. So when you do the manipulation, your fulcrum is keeping the thumb is to keep your head of the talus fixed there as it is, so that when you're manipulating, the talus doesn't move. When you're manipulating, only the calcaneo pedis together moves as one unit. And in that, you have to understand the next part. In the next part is, so this is a dynamic movement of a normal foot. Can you see that? That's
Yes.
a
Yes.
supinated foot. And as you abduct the foot naturally gets corrected from supination to a normal positions. So that's normal kinematically coupled subtalar joint movement. So similarly, when you view it from the side, that's how it looks. When you manipulate it, then you abduct the foot, the heel goes into valgus, the foot goes from supination to a normal and then to a pronated position. So that's normal kinematically coupled movement of the foot. This is what you need to understand. So that is what is the picture shown by Dr. Shafiq Pirani in his first lecture. This is when you abduct the supinated foot, you have hind foot varus getting corrected naturally without ever having to touch or manipulate the calcaneus. Thou shalt not touch the calcaneum. If you touch the calcaneum, you prevent the calcaneum from going from varus to valgus. You prevent correction of the deformity. So it's important for you to recognize you abduct the foot. But here there is a little catch. And what is the catch? And the catch is you do not abduct a pronated foot. So you do not abduct a pronated foot. When you do that, is there a possibility of my camera coming on?
Yeah, but the bandwidth is issue somewhat. Your
Yes,
voice
see,
is cutting.
I will.
I can make you. I can make it. No issue. No issue, sir.
And Matthew,
I,
a small request. We are running a bit late, so like we have a lot of things to cover. So
Yeah, I'll.
now you will be there. You just accept my request to have a camera.
Okay.
You are there. But if the bandwidth will be low, I have to cut your sacrifice first your video. That's all.
Okay. So here is this. So you have your thumb on the fulcrum. Then, as in the manipulation, the first step is supinate the forefoot. Why do you have to do that? That's because in a normal foot, the hind foot is in more varus position and more supinated position than the forefoot. Natural tendency of the foot is to go into slight pronation. So the forefoot is in pronation in relation to the hind foot. So your job, the first step is with your long finger, the middle finger, beneath the first ray, you elevate the first ray into a supinated position of the foot. Now the hind foot and the forefoot are in alignment. They are same degree of supination. Then you abduct the foot and the correction happens nicely. So the supination is the first step, using your long ray, and then abduction is the next step. Every time you do this manipulation, the hind foot correction happens naturally without your having to touch the hind foot. It happens. But on the other hand, if I pronate and then correct, the correction doesn't happen. Can you see that? Correction doesn't happen. The foot is locked. So the key to every manipulation is supinate the foot first with your thumb on the fulcrum, abduct it. That's the message that I have to give with the patho anatomy is based on the subtalar movement. Again, coming back to the boat analogy. I didn't understand what is the analogy. So roll the foot into supination. This is rolling. You roll the foot into supination. You yaw the foot into abduction. The pitching correction of the forefoot equinus and a little of the hindfoot equinus happens naturally. You don't dorsiflex forcefully to prevent a rocker bottom. So therefore, roll the foot into supination, yaw the foot into abduction. The pitching correction happens naturally. However, if your thumb is at the wrong place, it's in the calcaneum, you again prevent any movement. So the no here is to show that you cannot correct it without your thumb being on the talar head. You need to understand that. So that this, if you put your thumb here, this movement of the calcaneum that is happening will be prevented. So that's what I have to demonstrate. In Kite's technique, the calcaneum happened to be touched and the thumb was on the calcaneum. The fulcrum was calcaneocuboid joint. You corrected it by shifting it 1 centimeter up to the talar head, and that is your new fulcrum. And therefore, that blocking of calcaneum which happened in Kite's method does not happen in the Ponseti method. So we need to understand this. If you have your thumb on the calcaneum, correction doesn't happen. There, can you see that? It just doesn't happen. So this model is a beautiful model to understand the kinematic coupling that happens in the subtalar joint movement as described by Feraboff, as described by the boat analog. I'll stop here.
Thank you, sir. Thank you. It was a nice description of kinematics coupling. So now I would like ask to Dr. Safiq, sir. So how we will assess and how we will quantitate the deformity, like as a Pirani scoring on a own Pirani's mouth. So we are eagerly waiting about how we will score the Pirani scoring.
Sir, can you unmute
speaker
yourself? Unmute.
Thank you very much. Very, very interesting talk by Dr. Matthew, and is referring to a boat. I'm just going to see if I can get myself organized here.
Yeah.
So for the introduction and for the question as to how do you know you're making a difference? So the Pirani score, how and why. So what I'd like to do is to describe what it is and what it is not, its validity and reliability and its usefulness. So we all know diabetes. It's classified as type 1, type 2, and other specific types. The importance of this is that this is a classification, and once you're diabetic type 1, you always type 1 diabetic for the rest of your life. You don't move usually. And it determines the treatment and the prognosis, but it doesn't determine the treatment at the specific clinic visit. That depends on the blood sugar. The blood sugar is what is measured, not the type of diabetes at every visit. In a similar way, the Pirani score must not be thought of as a classification. It's not a classification, it's an assessment. It's a measurement of, if you want, the blood sugar of a foot. Think of it that way. And then the treatment you do will depend on what the Pirani score is. And it helps because it helps answer these questions. Is the correction progressing satisfactorily? Is the tenotomy indicated? Is the bracing indicated? And is the deformity relapsing? If you measure the blood sugar, you'll know if you're heading right or heading wrong with the dosage. If you measure the Pirani score, this is one way in which you can help. So this, the story of the Pirani score is that it initially started out with 10 items. 6 we were found to be not reliable, so it's down now to 6 items. We determined that over 20 years ago. And we also decided that rather than being very complicated, it'd be very simple. Each item could be either 0, half, or 1, rather than quarter and 3/4. It makes it more complicated. So here's the principle. If there's no deformity, it's 0. So this is the curvature of the lateral border of the foot. If there's a mild deformity, it's 0.5. And if it's very deformed, it's a 1. So each thing can be scored 0, half, or 1. So here are the signs. This is a medial crease, very dented. You can look at, if you look at the thumb, the crease on the anterior aspect of your thumb, you'll see when I bend it like this, it's a very deep a bend. That will be a 1. This would be a half where there's no dent, and the 0 would be if you look at the palm, the little creases on the palm of your hand, that would be a 0. The foot is normally a bit boomerang shaped like this, with a curve of the lateral cuboid joint, calcaneal cuboid joint. Half is a gentle curve, and 1 is a 0 for curvature of the lateral border of the foot. The talar head, as Matthew and Dr. Ponseti point out, is really a key item. So to elicit the talar head sign, you need to put your thumb over the talar head, and like this, so you feel it, and then you abduct the foot, and you want to see what's happening with the navicular. And the best way I could explain it is with these 3 diagrams. If the posterior medial retracting fibrosis is relaxed, and you abduct the foot, then the navicular slides between the tip of the thumb and the head of the talus. So when you have a sign of 0, you cannot feel the talar head. You cannot feel the talar head because it's been pushed away by the navicular. If when you abduct and the navicular does not even touch the thumb because it hasn't moved, that is a 1. And if you can feel both, then it's a half. Okay, so it's a difficult thing, but you have to kind of focus on that a little bit. The empty heel sign, this really reflects on contracture posteriorly, and you push on the corner of the heel right like that, and if you feel the calcaneus is right there, and so the example is if you touch your forehead and the bone is right there, that's a 0. Okay. Now if you touch here and there's space, or the thumb, the index finger goes into the heel a little bit before it touches, that's a half. And the example of that is if you push on your nose, there's some softness and then it gets hard, and that's a half. And then here, if you push and you can't feel it, that's a 1. And the example I would give on your own hands is if you push on your finger eminence like this, you can't feel the first metacarpal, and that's a 1. Posterior crease, a similar principle as I explained regarding the medial crease, 1, half, and 0. And then rigid equinus, if you push your foot up and you only get to neutral, that's a 0.5. If it doesn't get to neutral, it's a 1. If it gets above a neutral, it's a 0. And so those are the 6 signs. We tested those 6 signs. We had 300 consecutive club feet with 3 independent observers, and we tested it over a period of time. And we did the kappa statistic, and the kappa statistic showed almost perfect inter-observer reliability. And that's actually important, because if there's no inter-observer reliability, then measuring the score, it becomes more concerning. How about validity? Are we actually measuring what is important to measure? So we all have been shown the pathology, and what we did was we had a number of feet where, as the feet were correcting, we took MRIs at regular intervals, and we then compared those to the scores. And what we did was we created an MRI score. So for example, just as in the foot, you could see this is the calcaneal cuboid joint. This is a 1 where it's quite deranged, right? And a half is where the joint is actually reduced, but it's oblique. And a 0 is where the joint is corrected. And so we had an MRI score, and we had a midfoot score and we compared. Here you see an example of the 0, half, and 1 for the hindfoot, the hindfoot score. And we compared the clinical score and the MRI score in 19 feet, both the Pirani midfoot score and the MRI midfoot score, as well as the MRI hindfoot score and the Pirani hindfoot score. And we found that there was an excellent correlation, so that we were satisfied that we were measuring the right thing, that we had a score that was both reliable and valid. So now, what? Well, just like you measure the blood sugar over a period of time, you can also measure the Pirani score over a period of time. And if you wish, you can create a Pirani score graph, which is great for educating residents and medical students as to what should happen. Because you can see, if you can have a total Pirani score of 6, a hindfoot score of 3, midfoot score of 3, and as you apply these casts that we talked about, these effective casts, you can see how the scores change. And just as Dr. Ponseti described, the midfoot score should go down first. And when the midfoot score is zero or very low, then you can do the tenotomy. So this is your indication for doing a tenotomy, is that when the head of the talus score is 0 and the midfoot score is 0 or 0.5, you can do the tenotomy. And then when you take the cast off, the score should not have increased. If it's increased, you need to go back into a cast. If it has not increased, then you can go for bracing. So this is how the Pirani score helps you understand what's going on. And here's an example. This is a foot, curved lateral border 1, medial crease 1, lateral head of talus 1, posterior crease 1. This is a 6 out of 6 Pirani score. Here you can see now the midfoot score is 0.5. The head of talus is 0. This is the 0.5 midfoot crease here. The hindfoot score is still high. This is where the tenotomy is indicated. And when you do the tenotomy, you can see that the hindfoot score drops down. You can see the ankle is dorsiflexed. So this is what we typically see. And this is a situation where you wouldn't want to do a tenotomy, because sometimes you get club feet where both correct at the same time. It's very rare to do a tenotomy here if the hindfoot score and the midfoot score are low. Here is where the bracing is indicated. As I mentioned, the score should be less than 0.5, less than 1 each. And then here we can see an interesting example of where the first cast was effective, the second cast was effective, the Pirani score is going down, third cast was ineffective. You can see it's not in the right position, it's in the position of the first cast, and the scores go up. So this tells you, if you're not monitoring properly, you can see that, okay, the problem here was an ineffective cast, or something else happened. Maybe the parents took the cast off early because it got wet, or there was a swelling or something, and you can see that. And then another example you see is when the child is not wearing a brace and they come back, and after a few weeks the scores are going up. That tells you there's a relapse, and you have to find a reason why. And another place where it can tell you what's going on is, why is this person taking so long to correct his club foot? Is there a problem in the club foot, or is there a problem in the technique? And so these are all things that you can measure as you go along with the Pirani score. And it's been quite widely reported in different places, lots of different articles that have used the Pirani score to measure what they're doing. So in summary, the Pirani score, it should not be thought of a classification. It should be thought of an assessment of the amount of deformity. They're different things. And the Pirani score is useful to assess the amount of deformity, to facilitate day-to-day treatment decisions. It facilitates day-to-day treatment decisions. And it tells you, or is helpful in assessing if the deformity is correcting satisfactorily, is tenotomy indicated or not, is bracing indicated or not, and is there recurrence? Thank you.
Thank you, sir, for a bright light on a Pirani scoring. Now, I would like to ask Dr. Matthew Varghese, sir. So that nowadays there is various splint model is available, various braces available. So according to you, which kind of brace is preferable, and what are the signs of that bracing?
Yeah, I'm starting my brace.
Yeah, you start your presentation. In between, there are 1 or 2 questions are there. Already it is answered in your lecture, but still I have to mention, that's why I'm mentioning. Dr. Atul Srivastav has feared that if we cut the total tendon, what happens? But you have already mentioned that we are going to cut the total tendo Achilles tendon, right, sir? Pirani sir?
Yes, we cut the tendon, and what happens is that the ultrasound has shown that there's a gap created up to 1.5 centimeters. And in the gap, now I just take you to analogy. You know, there's a saying that if you have a fractured femur, a birth fracture, fractured femur, the management is you simply have to put a Pavlik harness on. Doesn't matter how the bone looks, it'll be healed in 2 weeks.
Right.
Why? How does that happen? Right. It's
Right.
the same thing with a cut tendon in an infant. Right.
Yeah. The similar
within,
question. Yeah.
Within 3 weeks, it heals.
Okay.
Not, of course, with bone, but with new tendon and some fibrosis.
Right.
Yes.
Right, sir.
Yeah,
Right, sir.
yeah, Safik sir. When
The
when
next question, can I ask the next question? Some of the people are advising of doing tenotomy with the needle. The same Pope is heard with the needle also? That is the question.
I have no experience with using the needle, but I think that, whatever you use, so long as you get that sudden ankle extension, and whether you get that immediate dorsiflexion, that is the key, right?
Okay, sir.
My only worry is where the sharp side of the needle is. It's on the end, whereas with the blade, the sharp side is to the side. So it depends how you do it. The technique might be a little bit different.
Okay. Dhiren wants to add something.
Yeah, like see the click or the clunk what we hear is because of like when the tendon is cut. So whether you use knife, whether you use a needle, that's a tool for cutting the tendon. But
Yes.
the sound is suggesting that we have cut the tendon completely. So the complete tenotomy is done. That's only when we hear that sound. So that's very important. And without that, always try to make sure that the tendon is cut completely. So that's a very important sound. And if you don't hear that, then definitely there is something wrong.
Okay. So the sound is there with the needle also, right?
Yeah.
That was the answer. Yeah.
yeah,
Sir.
Navin
And
bhai,
the sound is so big, like the person who is standing by the side will also like hear that and will feel that there is a sudden loss of movement. So it's that big.
Sudden increase of the motion.
Yeah. Or
Okay.
give way.
Give it. Yeah.
yeah,
Kamlesh
Navin
bhai,
bhai,
okay.
yeah, I
Yeah.
want to add one question to Safik sir. If suppose child is more than 8 months or 1 year old, so you do a complete tenotomy at the same, or and is there is a difference?
I used to be very careful of my age limit, but then I'm now doing complete tenotomies instead of open tendo Achilles lengthening up to age 4. Because up to age 4, others go up to age 8, age 9. Colleagues in Brazil, maybe your experience, Matthew, in Delhi. I'm sure you know much more. You see many more of these older children than I do. What is your experience?
When I started off in 2003, 2002, 2003, earlier we were doing only tenotomies in less than 1 year. After that was TA lengthening. Then we changed to less than 3. Then we changed to less than 5. Now age is no bar. Any person who has an equinus and you want to correct it, we can correct it with a tenotomy, a total tenotomy. I have patients that are 23-year-old, 24-year-old, had a complete transaction and are able to walk on tiptoe, bilateral complete transaction for clubfoot, and they are able to walk on tiptoe after surgery. So there is full regeneration of the tendon. Do not worry about the age criteria.
Age criteria.
Good message.
Yeah. Thank you, sir.
Go ahead, sir. Make it a full screen, sir. Make it a full screen. Matthew, sir.
Oh, that's me, huh?
Yeah. I think it's yours.
So the question was asked, there are many varieties of braces available. So how do you choose and what is the principle of a brace? The principle of the brace is in the name. It is a foot abduction brace. What did we do in our kinematic coupling? We supinated the foot and abducted it. Every time we supinated and abducted. The first cast with a lot of supination. As the correction happened, the supination reduced, it is only abduction. That's the key. In a normal foot, the degree of abduction is almost 70 degrees. So in a corrected foot after tenotomy, and that 70-degree happens after tenotomy. That 70-degree abduction should be possible if you run a good manipulation and a good casting and a good correction. So that's what you maintain by maintaining the abduction of the foot in a brace. That's the foot abduction brace. So whatever be the material with which the brace is made, whatever be, whether it is synthetic, whether it is steel, whether it is leather, whether it what the key principle is abduction in an infant to 70 degrees of abduction. And that is possible only if you have an interconnecting bar. So that's what we have. And we need to do this because the tendency for recurrence is a very stubborn tendency. And unless we maintain the correction in a foot abduction brace, the foot will recur back into a deformed position. So bracing is essential to maintain the correction achieved in Ponseti casting and in tenotomy. So this is the foot abduction orthosis that we have, the classical one. We have the abduction bar and the feet held in abduction. So there are different varieties. The names are not important. The principle is important. Abduction of the foot. And to maintain the abduction, you have to have the bar. The top one is the one that I use, and that is the Steenbeek brace. The Steenbeek, this is a Dennis Brown splint. But remember, a Dennis Brown splint originally had only 15-degree abduction. But the same brace can be converted into a foot abduction brace post Ponseti treatment by increasing the abduction to 70 degrees. And that is what is done. So if it is bilateral, both feet in 70 degree. If it is unilateral, the normal side is in 45 to 50 degrees and the abnormal corrected side is 70 degrees of abduction. So this is the technique of abduction that we have. The classic John Mitchell designed this brace for Dr. Ponseti. Daub had the articulated brace so that there could be some movement. Our own Dr. Vrisha Madhuri has the Padma foot brace that is there. That is a very wonderful acceptance among children. So the Padma brace is there. But each one, the key principle is abduction. The advantage that Dr. Shafiq Pirani in his Uganda Clubfoot program with Michael Steenbeck designing this using local materials, local leather, local plywood, and local steel to make this very cost effective. $7 was what was reported by Michael Steenbeck in the Uganda Clubfoot program. So the key principle is feet of the shoe attached to a bar, holding the feet in 70-degree abduction. It is turned in about 15-degree dorsiflexion. The width of the bar is to the tips of the points of the shoulder, within an inch of that. Points of the shoulder. If you keep it too much, the adherence to the protocol will be poor. It is uncomfortable, too much of abduction. Too much of abduction also puts the hip at risk to AVN. We don't want that. So this is an optimal level within an inch of the shoulder width. You have the brace and it comes in our place, since we have many older children also, from size 4 to size 20. That's what we have. So this is the brace that we have. It is important to prevent recurrence. It has a bar. There is a hole there that is to see if the heel is fitting well into the shoe. And this counter has to be well molded around the heel. And you should make sure that that's the hole there to look at. The heel is well placed in the insole. And the counselors that we have in our Clubfoot program, we have this little chart which tells you the various angles, whether they are correct or not. So that is the Seek brace that I have. Two sizes are there. That's the larger size. That's the smaller size. The Steenbeek brace, there is a bar. Feet are held in 70-degree abduction. And we do not want to make this counter too high. If you make it too high, that's not acceptable. The child can, using this as a fulcrum, can kick out the heel. This is a low counter, normal footwear. When you dorsiflex, the heel doesn't come. When you increase the counter higher up, this becomes the fulcrum. And when you plantar flex, these are slides of Dr. Michael Steen, this here and the heel comes out. Can you see that? So the equinus will recur if you have a high counter. So it's important for you to have a low counter and to have an abduction of 70 degrees. So the child, whatever be the age, wears it. And failure to, in fact, Dr. Shafiq Piranmi taught me this, that the word to be used is adherence to protocol, not compliance. So failure to adhere to the ROSE protocol is the most important cause for recurrence of these deformities. So we need to understand how do you measure it, how do you fit it, and the protocol for brace is first 3 months, 23 hours a day. The brace can be removed for 30 minutes to an hour, stretching, bathing, and leaving the child a little free. After that, nighttime and nap time brace. Why nighttime and nap time? Because these kids are very intelligent. They will recognize that during daytime when they sleep, they don't have the brace. So the adherence to the protocol of brace wearing by the child, he will keep crying till the parents remove it, or the grandparents will remove it. So we need to have it nighttime and nap time for 4 to 5 years. It works out to be these kids sleep from anywhere from 10 to 12 hours. And therefore, you need to have that many hours. Make sure that the heel is placed well, tie it nicely, and make sure the child is comfortable. So a comfortably fitting brace is the key to adherence to protocol. Call the child after 1 week because a new brace can be troubling, can be irritating, can cause a blister. Check for that within the first week. After that, call after 6 weeks. After that, 3 months till the child is 2 years, and then 6 monthly till the child is 4 or 5 years. That is what we have. And we teach them how to wear the brace, how to tie the laces, how to check for the heel fitting, and ask them if they have any problem. Don't let this happen. Over enthusiastic parents, child cried, didn't come back for follow-up, came back with this, not acceptable. So it's important that we check the fitting is well, check the heel is well placed. Initially, there may be a little pull out, difficulty, but then the child will manage. And every time the child comes for follow-up, have the score, the Pirani scoring to be done, tells you about adherence to protocol and tells you about early recurrence of the brace. So these are all the used braces. We know by the wear and tear that these braces have been used well, and little baby will move around. Many of them will stand on it. Earlier, the steel was softer, so they would bend it standing on one edge of a table. So now we use a stiffer steel so that it doesn't bend easily. Older children, we do not want to do. So what do? When they go to school, we give them an AFO. When they come back from school, we give them a foot abduction brace. This was a patient, somebody else's patient came to me, sir, what do we do for this brace? For a moment, I was stumped. I told them, in such a child, this is a streetal dysplasia, one side auto amputation, other side clubfoot deformity. Fit a prosthesis on the other side and have a foot abduction brace. That's the way to correct that. Thank you.
Thank you, sir. It was a nice talk for a bracing. So I would like to ask Dr. Safik sir. So we know the principles of Ponseti corrections, and we follow also, but the results are differ. So what are the common errors or what are the common mistakes frequently we do, and how to handle that common errors?
Once you start sharing, can I ask few questions? Come. Dr. DP Dhodkia from Rajkot is asking, any role of tibial rotation or torsion? Does it need a special treatment?
Are you asking me?
Yeah, you or Dr. Safik Pirani. Anyone can answer.
Tibial torsion is not a primary deformity of clubfoot. Earlier, we used to think it is a secondary deformity, secondary to the child walking on the foot for a longer time. So we do not consider that as a primary deformity. We do not have to worry about it. I have not done derotational, torsional correction osteochild with clubfoot. I don't know what is Dr. Shafiq Pirani's experience. I have not had to do it. Once you correct the deformity, just a foot abduction brace is all that is required.
Okay. The next question is about your kinematics. That is, please explain the parallelism of the talus and calcaneum in the CTV.
Parallelism. Okay. When you have a normal X-ray of the foot, if you see normally corrected foot, if you see that the calcaneum is at an angle to the talus. So this lateral talocalcaneal angle is anywhere between 25 to 45 or 30 to 50 degrees or so. So this angle, if your correction of the hindfoot equinus is not good, the heel remains up, the forefoot portion of the calcaneus remains down. Normally, the anterior portion of the calcaneum is upwardly directed. But if the equinus, and that is assuming equinus is corrected foot in a normal foot. But if the equinus is not corrected well, the hind foot stays up, the forefoot portion, anterior portion of the calcaneum is down. In this, on a lateral X-ray, the talus and calcaneum long axis are parallel to each other. That's a poorly corrected radiological marker for equinus, persistent equinus. So that's parallelism of talus and calcaneum.
Okay, sir. Now, in the follow-up question, it is a question to Dr. Pirani, sir. Is there a role of the serial X-rays to assess the correction of the Pirani score? Because MRI is an expensive proposition for many. So, is there any study or anybody has tried, or is it useful or not?
Not in almost every case. There's no need for X-rays. Before I expand, I'm just wondering, shall I start the talk? I don't know what the timing is like.
Okay, sir. Okay, go ahead, sir.
Do we have, because then, okay. So this slide, the point of this slide is that it shows Dr. Ponseti's, that he published his first article in 1963, and that included follow-up from 1948 to 1956. So what happened? How come there's still cases that are not going right? It's because people are not following the technique properly. And there are several different places where errors can happen. One point here is that the parent may not have...
Sir, I have to stop your video temporarily. There is some internet issue, sir, on your side. I stopped the video. Now you can go ahead.
Yes. Yes.
There is some bandwidth issue there.
All right, now?
You are heard, but it is slurred speech is coming.
Okay, all right. So the answer here is
now it is okay. Now it is okay, sir.
To talk to the parents so that they understand all their questions are answered. Or time talking to the parents about the treatment, because because they're part of the treatment in terms of bracing, and because they have to come for follow-up, you must get the parent buy-in, and the consequences, you will have adherence to treatment protocol. The second error is in not locating the head of the talus. If you don't locate the head of the talus accurately, and you put it where it's not supposed to be, your thumb, you'll lose your fulcrum. And so the importance of finding the head of the talus. Another error is ineffective manipulation and casting, as I discussed before, that if the baby's crying, the manipulation will not be effective. You won't get the reduction of the navicular over the head of the talus. When you remove the cast, there will be no improvement. And so the consequence is a very slow correction. The Pirani scores will not drop as quickly as they're supposed to. Casting alone is an error because you cannot do all the things you need to do to put the cast on and hold it in the correct position. The cast will be ineffective and the correction will be slow. If you fail to mold accurately, then what happens is that the cast will slip and you will see the disappearance of the toes, and the cast will become ineffective and also lead to complications such as a complex club foot, which is a separate issue. If you put your thumb on the calcaneal cuboid joint, this is Kite's error. And as Matthew so elegantly pointed out, the heel and the varus, heel varus and inversion cannot correct if you do that. If you pronate, this makes the cavus worse, not better. And so even though it makes the foot look better, overall alignment, the cavus is worse. Thou shalt not pronate. This was referred to before, a tenotomy error. Here you can see the parallelism where the calcaneus is pointing down, the heel is the talus is pointing down. That is where the heel varus still persists. And if you try and do a tenotomy here, the calcaneus still is pointing down in relationship to the talus, and so therefore you will get a midfoot break, which is something that Dhiren referred to before. And of course, that's why you want to do a tenotomy after the subtalar joint is fully corrected if you want to avoid this problem. Similarly, an incomplete tenotomy gives you the same thing. If you don't get that snap, if you have an incomplete tenotomy, you will, as you dorsiflex, you will crush the talar dove and you will create a midfoot break. So to avoid that, you must have full ankle extension and a complete tenotomy to do that. Errors, if you manipulate without a cast, some people in the past have done a manipulation and they come back and do physiotherapy and things like that. But it's very difficult if you don't hold the foot in the correct position to release that retracting fibrosis. So in my view, manipulation without casting or with ineffective casting is an error. And then lastly, if you have just a below knee cast, and this was very common in the 1960s, where before we had disposable diapers, and at least in North America, the answer that the orthopedic surgeon came up with was that, well, we'll just put a below knee cast on because that's just as good. And that is, of course, not the Ponseti method. If you don't put an above knee cast, the foot will not be held abducted under the talus, and the correction obtained by the manipulation is lost and the cast will slip. So those are just some of the common errors I wanted to refer to. Sorry, I took a little bit short time over that because I know we're short of time. Kamlesh, I think you're muted.
Now, okay. It's a great talk, sir, about common errors. Now I would like to ask Dr. Matthew, sir. So the treatment of the club foot, it's very easy, but relapse is very high. So how will you early identify the relapse and how will you manage? So we want a quick review about relapse, sir.
The deformity, as mentioned in the earlier lectures clearly by Dr. Pirani and brought out in literature, has a nasty tendency to recur. And the relapse is what we see most commonly when the brace protocol has not been followed. And most of the recurrences happen in the first 2 years. It is uncommon after 4 or 5 years. And relapse must be recognized early. And that's the importance of scoring the child using a Pirani score every time child comes to you. Every time scoring, even after correction of deformity, even after bracing has been done, every visit, you must score the child. When you score, you recognize an early recurrence of deformity. Early recurrence can be treated very well without any surgical intervention. Late recurrences in an older child are troublesome. So therefore, the key to correct the prevent early relapse, and therefore we have a brace protocol. Now this is Dr. Ponseti's original slide where he showed from 48 to 84 the brace protocol was sure. And his recurrence rate as high as 48% within the first year In the second year is about 45% or so. And he had recurrences right up to 6 years or so. So that was what made people relook it. And when the relooks was done, when the brace protocol was extended, the recurrence rate, the red bars are all the one reduction in the recurrence rates that was seen. So relapse usually the most common reason. The parents will deny the failure to use the brace protocol, but usually it is failure to use the brace. It's also because of your correction may have been inadequate. You didn't do a complete tenotomy. You didn't do a tenotomy when it was but necessary. You didn't have a full coverage of the talar head. You did a premature tenotomy. So all these are possibilities which will cause you to have a recurrence early on. And that must be anticipated. And therefore, your score must reach 0 score before you get to the brace protocol period. Your recurrence can also happen as part of growth spurt. So in an older patient, as growth is happening, particularly in the previously operated children, we find you've done the Ponseti technique. What correction, whatever the scarring is there from the pre-surgery, there is recurrence. There is a group of children, you find no reason, there is a recurrence. So this is Dr. Matthew Dobbs' paper, which talks about all the reference. The syndromic children have a higher recurrence chances than what we are seeing, and therefore, to prevent strict adherence to the protocol of brace, number one, put abduction brace with good abduction that is there in the brace, stretching of the Achilles tendon. How do we teach them that? Number one, slides or slopes, get them to climb uphill against the slope. And that is a very good way to stretch the Achilles tendon. Tell them to teach squatting. Squatting exercises stretches the tendon Achilles very nicely, and that prevents an early and so the difficulty there. Each time the child comes, you have to do the scoring. That's important. There is another recurrence that is there, and that is a relapse that happens in children with an overactive tibialis anterior. So these children with an overactive tibialis anterior will have a tendency for what is known as a dynamic supination. The word dynamic supination should be understood, and in some of them, because there is a recurrence in the forefoot, there is also recurrence in the hindfoot. Or you have a combination of hindfoot varus, which could have been incompletely corrected, persisting. So each of these are components of your failed treatment. So if you have recognized early on, there is a deformity which is coming back, hindfoot varus is there, little curved lateral border is there, restart Ponseti's casting again. Conventional casting. Usually tell the parents 2 or 3 casts and you correct it, go back to a good brace protocol. You don't have to do any resurgery. Invariably, you do not have to do any redo tenotomy also. It works well, and put them on exercises, put them on brace protocol, it will work well. However, dynamic supination will be seen in some children when they walk, the forefoot to supinate and raise up. So you can check this by a gait. Look at the foot, it is going supination, and you can check it by stroking. Look at this video. I hope the video works. When you stroke the undersurface, there, the tibialis anterior is overacting, and the clear dynamic supination. This is the normal side of the same boy. The other side was normal. See that? When you stroke the undersurface, see the way it goes into eversion. There is no dynamic supination in this. So here in a child who is more than 3 years, why more than 3 years? Because you do a total tibialis anterior tendon transfer in a child with dynamic supination from the medial side on the medial cuneiform and the adjacent part of the first metatarsal. You shift it from there to the lateral cuneiform. And the lateral cuneiform is not ossified in a child less than 2.5 or 3 years or so, approximately that time. So do I get an X-ray done? No. I wait for the child to be 3 years or so, check for dynamic supination. If it is there, I check the child under the image intensifier, see at the time I can make out, usually beyond 3 it is there. I take 3 as a cutoff, do a total tibialis anterior tendon transfer. So here, see the way the tibialis anterior is going from there to the base of the first metatarsal and the medial cuneiform. I take it away and put it here onto the lateral side. So therefore, this is the site of insertion, the lateral cuneiform. Here, see it under image intensifier, a total tibialis anterior tendon transfer. Take it away from there, 2 incisions, not 3 incisions. 1 incision to take out the tendon and 1 incision to insert it. And you put it there. This is the way I do it. Take it out through a little oblique incision at the base of the first metatarsal and middle cuneiform. Dissect it nicely, take it out, put it through a proline, and then take it out there. Identify, don't guess, identify it usually somewhere between the base of the third and the fourth metatarsal. You'll find the lateral cuneiform there, and put it into that, shift it subcutaneously into this lateral cuneiform and use a pull-out suture there. And this is what I use to gauze and rolled up malicos to hold it there. Keep a cast, and that is maintained for 5 weeks or so, and then give a brace for 3 months, and that's it. After total tibialis, it's not a split transfer, the total tibialis anterior tendon transfer, maintain the brace for 2 or 3 months, and that's it. After that, the child can be free from brace, dynamic supination gets corrected. So that's the way to handle a brace. Thank you very much. Okay.
Yeah. So so same continues that this talk. So how many cases the tibialis anterior transfer require?
How many cases?
Yeah, I mean percentage of the cases.
How many? I have in my clubfoot clinic about 80 patients come on one day. 80 patients. Sometime 90, sometime 100, sometime 70. So it's average is about 70 to 80 children that comes. For one clubfoot day, weekly clinic. How often do I do a tibialis anterior tendon transfer? With that volume, I probably do 1 or 2 in a month. That's all. So it's a very low. So between among 200-300 cases that are coming, I'm doing a very small number of tibialis anterior tendon transfer.
Matthew, what is the percentage of approximate percentage of recurrence or the relapse?
Relapse is depending. So it's, if you're looking at an overall relapse, including syndromic cases, that's pretty high. It will come to around 15 to 20%. But if you're looking at opathic clubfoot treated in our center, their relapse is less than 10%. Definitely. But the moment you bring in syndromic, especially I get a large number of syndromic with arthrogryposis. There, the recurrence rate is very high.
To add a comment there, you know, the incidence of relapse really depends on the adherence to bracing. And there was a paper shown from the Iowa group that with proper adherence to bracing, if the braces were worn, the relapse rate is less than 5%. And the braces not worn, the relapse rate is far higher. Yeah. So I think what Matthew is talking about is an excellent communication that he has with most of his patients, and they follow his prescription, and the reason is given, and that the tibialis anterior tendon transfer must not be thought of as an escape. It must be thought of as a failure.
It is.
It's a failure of communication usually between the physician and the clinician and the parent, and there's an opportunity here to understand exactly what the issue is that the parent is facing. And it may be as simple as the grandparent versus the parent. The grandparent wants to sleep and the parent wants to put the child, you know, and something like that. You know, so that's the area for exploration. Take every effort. Don't think of, we used to think of a posterior medial release as a way to correct the clubfoot.
Not at
Anybody
all.
doing a posterior medial release is accepting they failed, that they're committing this child to adulthood full of pain. So that's kind of thinking. And lastly, there is a paper that's actually been shown that the long-term outcomes following tibialis anterior tendon transfer are as good as the outcomes without a tendon transfer. So it is, in a way, it's an escape in a way, because if you have to do it, you can do it, and you won't get into trouble as long as the child won't get into trouble as long as there's no complications.
Yeah.
Sorry, long answer to short question.
Yeah. And what, sir, what is there is a quick, can I take some few quick questions, Najola, sir?
Yeah.
Yeah. So what is the earliest sign of recurrence?
You want to ask to
Yeah.
Matthew or?
Yeah, Matthew. I want to ask Dr. Matthew, sir. What is the earliest sign?
What I have been observing and what I use in my clinic, what I see is, if I look at the foot abduction of these children, and when I find the foot abduction is less than what it should in an infant, I expect the abduction to be good, 50 and 70 degree. If that is not happening, it gives me a clue that the brace protocol is probably not good. That's the earliest sign. Otherwise, most commonly what you see is equinus coming up. That is what. But the earliest sign, before equinus comes up, you find reduction of the abduction that is there. You kick it out passively. That's what I don't know what Dr. Pirani's experience is, but I have been consistently seeing this. Before the equinus comes on as a established deformity, I find restriction of the abduction movement as an important. I find that even true in the older children. And I have made it a habit now to routinely measure external rotation or abduction, whichever way you want to call it, in these kids.
I agree, Matthew, that equinus or loss of ankle dorsiflexion is quite important, as is measurement. So I think both needs to be measured, the foot abduction angle as well as the passive ankle dorsiflexion angle. And, somebody mentioned about internal tibial torsion. And so internal tibial torsion is actually important in this context, because if you have 30 degrees of internal tibial torsion or 20 degrees of internal tibial torsion, which many infants and many children do, you have to bear that in mind when you're measuring a foot abduction angle. So be very careful also to measure the head of talus sign in any child, because that's another trick as to whether there is a relapse happening. If you do get a low subtalar abduction angle, you have to kind of think about that. Is it really a relapse, or is it the fact that it's internal?
I use that as a guide to my understanding that the parents are not following the brace protocol well, because they're not wearing the foot abduction brace. So
yes,
is reducing. Soon you'll have equinus coming on.
Okay.
There's another very interesting sign, is that when you think there's a relapse, look carefully at the skin on the medial side of the heel and the ankle. And as you put the foot into abduction, and if it's stretched, if the skin is being stretched, it means the brace has not been on for a while. I don't think anybody's described that, but it's an interesting sign next time you look at it.
Okay, Dr.
Lack
Matthew.
of adherence.
Yeah. Dr. Matthew, there is a question of a transfer. Regarding your transfer, Dr. D. Bose from the Malda, West Bengal is asking, is there a chance of flat foot deformity if there is a transfer later on?
I have been doing tibialis anterior tendon transfer, and I have not had any case anybody having a flat foot as said to this. No.
Okay.
I've been doing it for quite many years now. I have not had any with long-term follow-up also. Though I have not made it, yes, I have not had any flat foot. No, Dr. Pirani, have you seen any?
No, I am not aware of any flat foot, and I don't think it's ever been reported. It's a bit like a non-union of an Achilles tendon after full tenotomy. I don't think there's been a case reported. There's worry about overcorrection, in open tendo Achilles lengthening, but I've never seen a case report of either of those issues.
No. I would have done over 3,000 tenotomies myself. I don't have a single case of incompetent endoachilles.
Okay, sir. Then the next question is from Dr. Jawar Jetwais. Is there a role of serial footprint during the treatment and relapse? Does it help anyway?
Severe?
Footprint, ink footprint will it serve as any sign to whether it's an incorrect correction or a relapse or something like that?
A
Serial footprints.
photogram is used as a tool, which, I used it in 2001 for a thesis for a postgraduate. But the Pirani scoring that you do gives you as good correction assessment. So the photogram needs a certain, ink to be applied on this foot, getting them to stand appropriately when you want to get them to stand. They don't like to stand. They are crying. The mother is hold on. All kinds of things are there. So a good photogram can give you a clue, but getting a good photogram in a small child is not an easy task. I found that in the thesis that I did for one of my postgraduates. So I don't routinely use it, but that has been used as a tool to show there is exaggerated cavers, to show that the heel is not touching. But a good Pirani scoring works as well. Simpler, very easy, takes you less than a minute.
It can be useful, I think, in one or two situations where the parents are they need convincing, and what you can do is you can have a footprint and give the parent the footprint. They take it, and then if in those situations where the parent wants to be convinced, then you can, once you have a footprint after full correction, and you have a footprint which shows some curvature happening, then the parent themselves has the opportunity to look at the evidence in the way they understand. They may not understand the Pirani score or things like that. So that's the only situation
I have used
that I would use
the
it.
program for long distance patients. I have patients coming from Bihar, I have Jharkhand and other patients, and I tell the parents, you take a photogram, put a date on that, take a photo on a cell phone and send it to me on WhatsApp. And 3 months down the line, repeat it and then send it to me. So I use that as a tool for long distance patients very occasionally, not regularly.
Oh, okay. As a screening tool. Okay.
As a screening tool from long distance, so that they don't have to come all the me.
Okay. The now next question to Dr. Matthew is, kindly explain the modified Ponseti manipulation for atypical club foot with the deep plantaris crease.
That is a little tricky. I wish I had anticipated
Do,
this.
do, you, do you want to explain on a model? Now we can have a full your video.
Um, okay, I'll explain it on this.
Yeah.
Okay.
Now I put your full video. Yeah.
Is it visible?
Yeah. Yeah. Just keep your hand little down. Yeah.
Now, just remember, in the modified Ponseti method, when do you do it? You do it when the child has developed a complex clubfoot. What happens in a complex clubfoot? So first thing is to understand the pathoanatomy. For Ponseti's manipulation, you understood kinematics of the subtle joint, and you understood the pathoanatomy and you manipulated. In this, what is the pathoanatomy? A cast that is slipped back, and because it is slipped back, the heel is gone into the cylindrical portion of the cast, it has gone back, and you have equinus worsening. And the midfoot now, because it is in that position, the edge of the ankle of the calf now comes to the midfoot region. And you have this portion of the forefoot at the tarso metatarsal joint going into plantar flexion. So the deformity in a complex clubfoot fulcrum is tarso-metatarsal joint, not the talo-navicular joint in the classical clubfoot. So where the deformity is, that is where your new fulcrum for correction and manipulation happens. So when the deformity is plantar flexion there, my first fulcrum which is fixed is the tarsum. And
Your hand is coming in between. So just
okay,
okay.
so the fulcrum is the tarsal bone, the cuneiforms, and the cuboid here, and the correction is here. Can you see that? So it is
Yeah.
plantar flex. It is plantar flex like that, and I'm pushing it into dorsiflexion. But don't worry, this will not cause a rocker bottom because you're distal to the talar. If you were here, it will cause a dorsiflexion there. But here, it is on the tarsal bone, and you're dorsiflexing this. So your modified manipulation is fulcrum is different. Fulcrum is tarso metatarsal joint. And you dorsiflex the metatarsals. That's the modified manipulation. I
Okay,
hope
sir.
that's clear.
Yeah. Now, again, somebody is asking the question, Dr. Keval Patel from Himmatnagar to Dr. Safik Pirani. He's asking peculiar question that in every case, tenotomy is required even if the this equinus score is 0.5.
Thank you for the question.
Yeah.
Actually, to answer to that question is no. The answer is no.
Your internet connection is a little weak.
Again, of how the Pirani score helps. I'm going to just share my screen.
Okay, you want to
I'm
share
so
it?
sorry.
Okay. Okay.
Yeah.
I have to stop your videos for a while. I have to stop your video for a while, so that your bandwidth is a problem. Okay, now go ahead, sir.
So the answer to that question.
Yes, sir.
Okay, so the So the answer to that question is no. There's about maybe 5% of cases where the Pirani score is high, both the midfoot components and the hindfoot components. But in 5% of cases, when you follow can I show this slide now? The point is, if in 5% of the cases, the midfoot score and the hindfoot score drop at the same club foot without a tenotomy, there's no need to perform a tenotomy.
Okay.
The principle is no, not all do, but you only need to do the tenotomy if the hindfoot is not corrected.
Okay, sir.
You do not need to do a tenotomy in about 5% of cases. I agree with that. Maybe less than 5%. The tenotomy rate in my clinic is almost 98%. The ones where you don't need it are usually the postural club, where the equinus gets corrected in about 3 casts and the patient gets corrected in about 3 or 4 casts at best. The postural clubfoot.
Sir, I've asked to start
yes,
your
exactly
video.
Right. So,
start your video, sir.
My video?
Okay.
No. It's okay. Now, Dr. Safik Pirani. Okay. There are. I will have to stop. I have to stop your.
Here on.
Sir, I have to stop temporarily. Temporarily, I'm stopping your video because your voice is cutting.
As you wish. Go ahead.
Okay. You can speak now. You're audible now, sir.
Okay. No, I was just go ahead with the questions. If my video was working, I would show 2 slides on complex clubfoot. But if it is not working, carry on with questions.
Okay. Once your internet connection becomes stable, we'll do that. Okay. Then the next question is, please explain the type 2 Ponseti technique. Type 2 Ponseti technique. Dr. Matthew Varghese.
I'm not familiar
Type
with that.
2, I'm not familiar with that. I don't know.
Okay. And Dr. Jiten Shukla is asking, is the hindfoot varus or equinus early to relapse and the forefoot the most resistant to correction? Your opinion, please.
The most important clue to relapse is, as Dr. Matthew suggested, is some loss of abduction of the calcaneus under the talus and accompanied by loss of ankle dorsiflexion under the tibia. The correction, I think, with the Ponseti method is actually very effective. There's very few cases, if hardly ever, have I not been able to achieve a full correction with serial casting in the original Ponseti method under the age of 4 or even 5. I don't know what your experience is, but I've never had to, for example, add a plantar fascia release or anything like that to correct cavus. normally everything corrects nicely, particularly if we'd not created a problem beforehand with inappropriate technique. Matthew, what do you think?
Sorry, I couldn't hear that part, the last part.
Well, the question was the order in which relapse occurs and which is the most difficult component to correct. Yeah. And in my view, it's, as you said before, the earliest components to relapse are the hind foot rather than the midfoot. And my answer is that I've never had a problem re-obtaining full correction with 2 or 3 sets of casts applied at 2 weekly intervals. It's never been the situation where I found one component harder to correct than another component.
Yeah, if you do 3 casts in, you're able to correct that recurrence of deformity.
Yeah,
we're able to.
Yeah. Yeah, the equinus may not correct.
Usually,
you might need to do the again.
Hindfoot equinus, and varus. Remember the normal picture that I showed? The moment the high heel is in equinus, the heel also is. It goes concurrently. So hindfoot equinus and varus go together.
Okay, Dr. Matthew sir, there is a question from Adapalli Srinivas Rao from Andhra Pradesh. Why FAB given up to 4 years of age? Any reason?
Yeah, that's why the original slide of Dr. Ponseti becomes useful. I enlarge this. My whole thing has become smaller.
Your mic, please. Keep your mic nearer, please.
Yeah. The reason why we have this, I don't know how to get this bigger.
You are trying to get your slides?
No, I can't see anything else that is happening.
Okay. You are not able to see it.
Yeah.
That won't happen. Now can you see?
Yeah, just repeat that question.
The question is, why FAB given up to 4 years of age? Any reason?
Yeah, the original slide of Dr. Ponseti clearly shows you that there is a percentage of children that have even up to 4 to 5 years. Ponseti initially was giving it only for 1 year or so. Subsequently, he changed it much later in life, but he changed it. And the period of bracing was continued to an older child up to 4, preferably 5 years, because there is about 5 to 6% recurrence rate that is possible beyond 5 years. It is not nil recurrence. There is still a smaller percentage. So in a child who has had a postural clubfoot, do you need to give it for 4 years? No. You may remove the bracing in 3 years' time or so. So you'll have to decide on a case-to-case basis. But as a normal, what we are following is up to 4 years, because as Ponseti described again, the retractile fibrous abnormal tissue for some reason persists till the child is 5 years or so. After that, tendency for that tissue to remain abnormal is reduced.
Okay, sir. Pirani sir, do you want to show your slides? Now I think your connection looks stable.
Yes, I will. So this is going back to complex clubfoot.
Yeah.
What is it and how can we manage it? And so you'll see here, this is a complex clubfoot. What has happened, a complex clubfoot, can you see it?
Yeah, we can see the slides, yeah. But I may have to close your video temporarily.
Okay.
So that your voice becomes clear, that's why.
You do what you have to.
Yes, sir. Yeah, you go ahead explaining the slides.
Yeah, you close my video then.
Yeah, I will close.
The slide. Huh?
I will close. Yes, the slide is okay, voice is okay, sir.
In complex clubfoot, usually the history is that the cast has slipped. And what happens is that when the cast slips, it dents the heel. So you get a flat heel, it smashes the heel. And the metatarsals are plantarflexed as the foot starts to slip in the cast. And so you get a deep plantar crease all the way across. And then as you have slackening of the plantar fascia, the hallux tends to go up into an extended position. so the hallux looks short. So these are the features, plus all the massive swelling that you see at the front here. You see the anterior skin line where it's virtually a straight line, and you can see the amount of fat that's over here. And this is a picture from Dr. Ponseti, and you can see the metatarsals plantar flex. So not only is there equinus, there's metatarsal plantar flexion, and on the AP view, you can see the metatarsals are abducted. So this is like a midfoot break into abduction. And so what needs to happen here is you need to correct both the equinus and the metatarsal plantar flexion without abducting too much and aggravating the midfoot break into abduction. So the technique that was described was that in this situation, you can find the head of the talus in the usual way. Dr. Ponseti always used to put his index finger behind the lateral malleolus, and then he would abduct the foot. The navicular would slide back over the head of the talus. Once he got to that, so he would cast until he got to 30 degrees of abduction. Then he changed his technique of casting so that he would have dorsal directed pressure on both the first and fifth metatarsal heads, and that would correct the plantar flexion at the metatarsal joint, and also correct the hind foot. And so here you go. There's again Dr. Ponseti's hands. He's dorsiflexing the first and fifth metatarsal using counter pressure with his index fingers on top of the proximal part of the midfoot. Hyperflexion of the metatarsals and rigid equinus was corrected simultaneously by grasping the foot by the ankle with both hands, whilst the thumbs under the metatarsals are pushed the foot into dorsiflexion as an assisted stabilize the knee inflection. So I thought I'd just show those slides just so that you can get just to expand,
a nice way.
Talked about exactly this maneuver, which is what Dr. Ponseti
Fantastic slides, sir. Fantastic slides.
How you recognize it.
Thank you, sir. Now the question is from Dr. Jaswinder.
I just wanted to share.
Yes, sir. Again, your voice has gone, sir. Hello.
Yeah.
You can go ahead, sir. We can hear you.
Sorry, what was the question?
And the question is, Dr. Jaswinder from Patna is asking to Matthew, sir, can you please share the casting and tenotomy protocol for an adult neglected clubfoot?
Adult.
Neglected clubfoot. Yeah. Protocol of plastering and tenotomy.
Correction for the term again, learned from from the WHO protocol. We do not like to call anything neglected. Untreated clubfoot.
Untreated. Okay.
Untreated clubfoot. Adult untreated means the structural changes in the bones have already taken place. Then you have to take a call. The patient is over 18 years. Then there is a problem. You have to ask them why they want to get it done. Because if you're not cautious in why you're getting it done, if it is a significant deformity, they will be walking very happily with a convex foot, and that convex foot becomes a nice rocker for them to conveniently walk. If you correct the deformity, soft tissue correction will not correct it. Ponseti manipulation alone will not correct it. It will get a partial correction, and subsequently you have to correct the residual deformity using bony procedures. You have a combination of soft tissue and bony procedures. So what do I do? If very severe deformity, I may do a few casts to see if there is any manipulative correction possible or not. And usually in the older patient, up to 14 is still okay in boys, up to 12, 13 in girls is okay. Beyond that, it becomes a little difficult. They have structural changes. It becomes difficult to correct only by Ponseti's method. You have to add on other techniques. It may be bony procedures, it may be fusions, it may be osteotomies. Something is required to correct it. It's an occasional patient who's come with a mild deformity. In them, you do the classical Ponseti method, followed by a tenotomy, and usually they are corrected in about 8-10 casts. These are the milder ones. But if it is a severe deformity, remember you need to add on other procedures. These are the children in whom I add on procedures which needs a combination of Ilizarov or Jess, followed by a procedure to do some selective fusions of the joints or osteotomies of the joints. So there
Okay.
is no one formula for each of them. You'll have
Yeah,
to see
yeah.
the severity of deformity, how they are walking. And especially with severe deformities with convex foot walking, using the foot as a rocker, be careful, the patient is not going to be happy. The only ones where I am a little more careful and sensitive are the girls for whom before marriage, cosmetic correction of the foot to normal side is an important factor for social reasons. And in them, I achieve a foot correction, but please, I'll always want the foot is stiff and straight, but it's not as supple as you would want.
Sir, the follow-up question is, what about the Jess gradual correction?
Jess is not a strong enough system for the older patient. It is not a good system for the younger patient at all. I don't use Jess at all in young patients. As I said, I use classical Ponseti's method up to 14 in boys, up to 12 or 13 in girls. All of them get corrected. Milder deformities which appear on X-rays, I'm not bothered. Foot looks nice and well corrected and do a tenotomy. It's only the older ones that I need to do I do Ilizarov modified with the foot assembly of Jess is very good, but that is not good for the stiff correction, which is very difficult with just 2 or 3 pins of Jess. So there a strong base of 2-ring Ilizarov fixation, marry that to a Jess fixation assembly, it's very simple and he can correct it. But remember, there is a problem with Jess. Jess is a non-specific correction of all the joints. All the joints get stretched out. It's not selective correction of where the deformity is. So
Okay.
just remember that.
It
And
is non-selective.
long-term problem with Jess is overall the foot is stiffer than what you like it to be.
Okay, sir. The next question from Dr. Jiten Shukla is, Dr. Matthew, sir, what is against the partial tibialis anterior transfer, and can a transfer be done as early as 3 years? Two questions in one question. Two questions are loaded in one question.
You do not do a tendon transfer in less than 3 years because of the insertion is not ossified. So you may put it into the intercuneiform joint. You may put it into the joint which is cuboid joint there. So you don't want to cause any problem by damaging in its joint. Identify the bone only after the bone is ossified, and that is about 3 years. 2.5 to 3 years. I keep a margin of 3 years. Why don't we do a partial tendon transfer? When you do a partial, I haven't done a randomized control trial. I have not read a paper specifically on this. The logic is if you leave a part of the tendon there, the tendency for the tendon would be to keep it back into supination. So you do a total tendon transfer. Why don't you do a total tendon transfer in cerebral palsy? The split tibialis anterior tendon transfer is a feature in cerebral palsy. Why don't you do a total transfer? Because if you do it, reversal of varus to valgus is a possibility. So therefore, you don't do a total transfer there, you do a split transfer there.
So
Okay, sir.
I just expand a little bit on Matthew's comments there. The, the rationale behind the tendon transfer is that you're taking a deforming force and you're making it into a corrective force. And Garceau in 1936 first described the tendon transfer, tibialis and the tendon transfer into the cuboid. And there were some situations of overcorrection. So that's why Dr. Ponseti, he also had that experience initially. That's why he chose the lateral cuneiform as the site of entry, because there the risk of overcorrection is very little because it's straight anterior from the ankle. So it's an easier operation to do a complete tendon transfer than a partial tendon transfer, because in a partial tendon transfer, it's very difficult to get the tension both correct on both sides. Total tendon transfer is much easier operation and has no disadvantages compared to a split. In fact, it has many advantages.
And remember, your tibialis posterior is there as an inverter.
Yeah.
So that's not a problem.
Yes.
Now the next question is, doesn't the 70-degree abduction can cause the valgus deformity in the later stage? It was from the previous talk. Somebody is seeing very late, started very late to see. So he's asking, doesn't the 70-degree abduction can cause the valgus deformity in later stage?
It doesn't cause problem because a normal foot also can be abducted to 70 degrees. However, in a child 3 years plus, you do not get that degree of abduction. There the degree of abduction is lesser. You need to look at the age of the child, because we see older children. And when we see older children, in older children, you're not able to get it to 70 degrees. So can we put a 70-degree abduction brace in these children? Yes, we can still do it, because all that abduction is not part of the abduction. In fact, Dr. Anil Agarwal from Chacha Nehru Hospital very beautifully demonstrated this. When you extend the hip and you extend the knee, part of the abduction is happening by external rotation of the whole leg at the hip joint. It is only when you flex that the abduction becomes completely at the foot level. So therefore, he demonstrated a dynamicity on extension. It is partially at the hip, partially at the foot. When you flex the knee, it is partially at it's almost all at the foot level. A small stress happens at the knee level also. And this is true in the older children. So the degree of abduction that you're able to achieve in the older children is not exactly 70 degrees, but 70 degrees in a child, and that is what you would achieve by trying to achieve normalcy in these children. You have to get 70-degree abduction. It doesn't lead to valgus, no.
Maybe I can illustrate in a different way. If you look at my wrist, right, if this is a club foot, then by getting 70 degrees of abduction, you're regaining the full range of motion in the wrist. So whatever degree of abduction you obtain at the end of correction is what you want to maintain. And that is where you want the brace to hold it like that. If you get it to here, you want to hold it there. Whatever is normal. And in infancy, it's 70 degrees. You don't want to brace it in this position after getting it corrected like that.
Good. Yes, sir. Now, is there any questions from the inside the, any comments want to do? Final comments, because I think Dr. Pirani sir has to go to his clinic now.
I have one question. One question.
Yes, sir.
I want to know what it is that you do in your environment to make the Ponseti method work, because the clubfoot is the same everywhere on the planet, but local conditions are different. And the curious question I have is, you make it work. So what is it that you have to do? Like Matthew, you described your situations there. I just want to know a few principles as to how you make it work in your situation, because your experience is huge. And then when we go to other places, we can say, well, don't sacrifice the Ponseti method principles, but how do you make it work in your situation?
That question.
Yes, Kamlesh, you can answer that question.
Yeah, but no, we will strictly follow the Ponseti principles. And in our private practice and in our like charitable hospital also, sometimes it will get, because sometimes charitable hospital will not apply full plaster by ourselves. But at that time we have to train our technicians. But in our hospitals, we'll strictly follow the Ponseti principle.
That's fine. I'm just situation, if you can follow everything, that's wonderful. But sometimes, when I'm cooking, I don't have salt, so I have to modify. I still want to make the dish proper. Actually, lacking salt is the real problem, but I may not have something else. So what is it that you have to do in your situation? Sometimes you think, and you find a solution.
So
what are the innovations you have done in the club foot?
Things,
Yeah.
Yes,
what I am
exactly.
thinking, like, same, because when we score the Pirani scoring, so we get a little bit difficulty initially. So what we do, we have started taking photographs of that. So we will make a whole photograph series of the Pirani scoring that will compare with our results. That after doing a photographs, clinical photograph of that foot. So we are also reassessing what we are doing Pirani scoring is right or not. So we have started taking photographs and we're comparing our photographs with Pirani scoring. Let's see how will work.
Excellent.
Yeah, within 6 months we will come back to that results.
Excellent. I was wondering whether there were some specific techniques you use in Gujarat to convince the parents, you know, to keep coming back to the clinic, because it's 20 visits over 4 years. So how do you do that? You know, it's other Gujaratis do, you know, because if they don't come back to the clinic, it's a problem.
Dhiren, you can say how you communicate with the patient, sir.
So basically, like the first of all, like to convincing them for the brace is one of the major issue. So there are various ways we use. Sometimes we give them that we have done our duty, and now it's the ball is in your court, and you have to maintain it. That's the one way. The second thing is like we use some element of threat by saying that if you don't use it properly, in that case we will lose the correction. Then in the follow-up, I use the dorsiflexion of the ankle as a most important criteria. And if there is an adequate dorsiflexion, I consider that like the child is safe and the chances of recurrence are less. So as soon as I notice that the dorsiflexion is becoming less, I make a note of it with a red pen in my case paper and explain to the family that there is a deterioration in comparison to the previous visit. And then I suggest that yes, at this point probably we can go back and we can have a good result if we increase or like maintain the brace protocol properly. So these are the small tricks which we do to influence our patients.
There are there are two follow-up questions, Dhiren. Any role of corrective shoes after all corrections, post corrections?
I don't use any corrective shoes. It's just the Ponseti brace or like the foot abduction brace which we use. During daytime, child can use whatever the family wants.
Okay. The one question has come is the cast slippage necessary for the complex clubfoot etiology? It can even be by birth with the deep plantar crease. And if it is by birth, do we follow same manipulations or different?
Like see, the complex clubfoot can be iatrogenic as I think explained by Shafiq, like when the foot slips in the plaster, that's one. But as the questioner said, that's a correct observation that it can be from birth also. And for that, what Matthew explained is really well, like you need to modify your Ponseti method to great extent, and you don't expect 70-degree of foot abduction in those patients.
Okay, fine.
Yes, I want to add, I want to, Safik sir, yes.
I have a couple of slides on that.
But I will have to stop your video because you are again a problem of your bandwidth. Sorry, sir. I have to just stopping your video, right? So we can have some bandwidth for your voice and the slide. Still, it will come gradually. It will come, sir. Can you make this slide full?
No problem. Please do.
No,
the difference between
no. You can go for the make slide full, sir. Make your PowerPoint presentation on. No issue, sir.
It's full right now.
Right, it's coming, gradually coming. But bandwidth is a problem somewhat.
Let me just try it again. Can you see it?
Yeah, we can see it now. Very well, sir.
Now?
We can see it, sir. Hello?
So, what I'm showing here, okay. What I'm showing here is what I call an atypical club foot.
Yeah.
Okay. It's what I'm showing here is a typical club foot.
Yeah, yes.
Can you hear me?
Yeah, we can hear you, but your voice is cutting in between. But still, we can understand what you're speaking, sir.
Hello. Yes. Can you hear me? Okay.
Yeah, now
So
it's okay. Now your bandwidth has improved.
this
Okay,
is
go ahead, sir.
8. Okay. So this child was born with this foot. And you can see the enormous amount of plantar of equinus, the round heel, the deep plantar crease, the cocciphallix, the posterior crease, and and the cavus. So this child was born like this. This was not a complex club foot, which is iatrogenic. This is congenital. And the reason why I talk about the difference is because that we have an MRI here, and you can see that the pathology here is really at the cuboid fifth metatarsal joint in the situation. The plantar flexion that Dr. Ponseti showed in his x-rays. And what the talonavicular joint really is not that badly affected. And that you can see after the first cast how much improvement there has been with that technique. Okay. Underlying syndrome. Right? So if you have a foot that looks like this after cast slippage, it's a cast, it's an idiopathic club foot that has been turned. It might be a syndromic club foot. That
Okay, sir. Okay. Your voice has gone partly. Can you speak something, sir?
I'm sorry.
Yeah. Now you're heard very well
Yes,
because
how about now? Can you hear me? Yeah, okay. Yeah. Matthew, have you seen that before? What's your experience with
Yeah,
the children who are born like that, or they're in the previous cast?
majority of children that we see with this deformity are the complex clubfoot, which are iatrogenic, to a slipped cast.
Yes.
But there is a small number. In fact, in a series of 20 cases, we had 4 cases of 8. So the expression has changed now. Earlier, all of them were known as atypical club feet. And the distinction between de novo deformity, which looked exactly like the atypical, was there in a certain number from birth. And majority of are the ones which are iatrogenic. So today the classification is the iatrogenic ones are called complex club feet, and the de novo ones are known as atypical club feet. And the atypical club feet, the predominant deformity is at the joint, which is distal to the fulcrum in a Ponseti's classical manuscript. This is not at the talonavicular, it is distal. So here we can one cast in supination and little abduction, or 2 casts in supination and little abduction. After that, you do the modified maneuver, and they all come beautifully corrected within the 6 casts that we have normally. The complex club also get corrected, and you have to see, has the talar head got reduced or reduced. If it is not reduced, first 1 or 2 casts to correct that, and then the modification should happen. Okay, so all this is done in a slip cast. There is initially edema, tender feet. The child will not allow casting properly, will be howling away, will not be relaxed, will cry constantly. Give a cast holiday anywhere from 2 to 6 weeks, depending how bad the complex club foot is. Usually 2 to 3 weeks is sufficient. I've had children whom have given 6 weeks cast holiday also. Reassure the parents. They are worried if you don't become bad again. Reassure the cast holiday is good for the child. At the end of the cast holiday, give this modified manipulation. And in the atypical clubfoot, you do the supination correction for 1 or 2 casts and then the modified manipulation if it is required.
Okay, the last question and then we wrap up, right? The last question is from Dr. Jawar Jetfa about counseling. You ask it. Do you have to deal with the parental counseling in congenital talipes equinovirus and prediction based on heredity?
Is that to
Maybe
me?
Yes, sir.
Of course, you need to do counseling. And in the Clubfoot program that we have created, every Clubfoot clinic has a counselor who is spending time with the parents and counseling them, allaying their fears, has a 24/7 helpline. So the Cure International India Clubfoot program has a counselor in every clinic, one-to-one relationship with the patient, and there's a 24/7 helpline talking to the parents, counseling them. So it's a teamwork. It's not a one man,
Yes, yes, sir.
one patient.
But the
Teamwork.
question is there any prenatal counseling? It is not parental. It is a prenatal counseling in congenital talipes
I'm
equinovirus.
coming to that.
Prediction based on the hereditary.
I'm coming to that. So there are 2 categories of patients. One that come to you in the prenatal stage, have come to you with the family history. There you have to reassure them this is a completely correctable deformity if you start the treatment early and follow up regularly. And you have to show them normal kids that come to your clinic. And when I tell them I have a football team of children claim corrected with clubfoot, oh, they are very excited. Oh, they can play football also. That's a very demanding sport. So they are very reassured. So that counseling of that form works in the family history parent with the family history of clubfoot that is there. Other is, so I have had boy and girl recently get married. There's a family history of clubfoot. They have been open about it and we've been counseling them. The other group is pregnant mothers who have had ultrasound done and have been diagnosed as having clubfoot. There it's a serious business of counseling. You have to spend a long time trying to ask. They come to you with the request that should we abort the child. So we tell them, no, please don't do that. The deformity is fully correctable. However, we always get them to have a full evaluation, that is from the obstetrician side. There's a family history, family tree that we make. If necessary, a genetic evaluation that is done, and then give the final counseling. But that is a very, very difficult counseling to do. You need a professionally trained counselor for such a thing.
You see, the issue is, Matthew points out, is one of fear. It's one of fear. It's not an orthopedic problem directly. It's but parents are afraid. And when you have parents that are afraid, you need people who know how to deal with fear. And that's why you need a counselor to deal with that fear issue, to make sure the parents are no longer afraid of their child being born and crippled and going to be like that for them. Now, the good thing about having a counselor in every clinic is that sometimes the doctor also needs counseling. So, it's very good, Matthew, that you have these counselors, because then the doctor can also be counseled to do the right thing. Anyway, gentlemen and ladies, I've had a very good time. I do have to leave. And so may I take this opportunity
Yes,
to say thank you very much.
Thank you
Thank you,
very
sir.
much.
Sir, thank you very much on behalf of the Gujarat Orthopedic Association. Very thank you much, sir.
No, I have a soft spot for Gujarat. Thank you so much.
Thank you, Safik sir. Thank you
Okay,
very
sir.
much
All right.
for
Yes,
spending
you
time with us.
you can leave the meeting, sir. You can leave the meeting, sir.
Thank you.
Thank you.
Thank you, sir.
Hello.
Yes.
If there are any points remaining to explain now, then you can complete and then we can just stop the streaming. Dr. Matthew, sir.
Yes.
Do you want to say any message or anything to concluding message to all the viewers? Let me tell you, 3184 with the highest hits.
Wow.
Yeah,
That's a large number.
yeah, very large number, very large number.
Yeah. Thank you very much, all of you. I think one key message that I have to do is the results of Ponseti method are so good. Please consider that as an option in every child. Adult, it's a different ballgame. But in every child, please consider the long-term results are far better with Ponseti method. However, learn the Ponseti method properly at detail is very important. That fulcrum recognition and the technique of manipulation and technique of casting must be learned hands-on. It is an important technique to be learned as a psychomotor skill, learn only do it. That's an important message that you have. And tenotomy, please understand, as a key performance indicator, we've recognized if your tenotomy rate that you expect in my clinic is about 95 to 80%, if it is less than 80%, there is something wrong that you're doing. Some of your children will have a higher recurrence rate. So your key performance indicator would be a brace protocol that goes on to at least 4 years, preferably 5 years, a tenotomy rate that is over 90%, and a recurrence rate that should be definitely less than 10% or so, preferably closer to 5%. That would be for idiopathic clubfoot. And please make sure, recognize the complex clubfoot early on. If a clinic is going on and it is not having a good casting rate, your complex clubfoot rate will go up. Please don't do that. That's iatrogenic. First, learn to recognize it, learn to prevent it, and once you've learned, and if you have it still, learn to treat it. That's an important tool before you run a clubfoot clinic.
Thank you, sir.
Thank you.
Dhiren,
Thank you very
do you
much.
want to say anything?
No,
Dhiren?
no, but thank you. Thank you.
Thank you,
Okay,
sir.
so I'm stopping the stream.